Welcome back to the 2026 APAICS Health Summit. I'm Tanya Layden, Vice President of Development and External Affairs at APAICS. Our next panel is The Care We Need, Building a Strong Health Workforce. Amid growing national shortages, the health workforce pipeline continues to fall short for AA and NHPI communities, where limited representation undermines access to culturally competent care. This panel explores how the provider shortage strains both patients and the few clinicians serving them, deepening burnout and widening equity gaps. I'm pleased to introduce CAPAC Executive Member Senator Mazie Hirono from Hawaii. Senator Hirono is a leader on the Senate Armed Services Committee and works tirelessly to reduce the cost of healthcare and improve access to insurance for families across the country. Please join me in welcoming Senator Hirono.
Aloha, I'm Senator Mazie Hirono, and I'm glad to join you all for the 2026 APEX Health Summit. We face a nationwide shortage in the healthcare workforce, deepening gaps in access to the care and straining our communities, resources, patients, and workers. These shortages affect millions of Americans, but especially fall short of the needs of historically marginalized groups, such as the AA-NHPI community. Members of the AA-NHPI community face unique health challenges, such as an increased rate incidence and mortality of certain cancers, like lung, stomach, and liver cancer, compared to their white counterparts. And among the lowest rates of mental health service utilization of any racial group. These health disparities highlight the importance of hiring workers who understand the specific needs of our communities to provide more effective care. Hawaii has the highest percentage of AA-NHPI residents in the country, and as of 2024, our state had over 4,500 healthcare position vacancies and needed an additional 800 physicians, a shortage only being made worse by the Trump administration, such as $1 billion in cuts to Medicaid and limits on how much money certain aspiring healthcare professionals can borrow for their education. Everyone should be able to receive the culturally competent healthcare they need, which is why we need to continue working to not only train more healthcare workers, but to foster diversity in the healthcare workforce to better serve all communities. Unfortunately, we have a regime that does not recognize the value of such a diverse workforce, and instead relentlessly attacks programs and initiatives that encourage diversity. In spite of these attacks, we must continue working to rebuild the healthcare workforce and improve our healthcare system to meet our communities where they are. Mahalo for APEX for hosting this important panel and for its dedication to promoting diversity and facilitating important discussions to find solutions on how we can better meet the needs of our communities. I'm proud to be your partner in the fight for healthcare access for all, and I remain committed to working with you to strengthen our healthcare workforce and ensuring that every member of our community can access the quality healthcare that fits their needs. Mahalo.
Our moderator for this panel, Rita Kaur Kuwahara, is the Senior Advisor for Medicine and Health Policy at the Association of Asian Pacific Community Health Organizations, a primary care internal medicine physician, and an APAICS Fellowship alumni. She also currently serves on the American College of Physicians National Health Equity Committee. Please welcome Rita and our panelists.
Thank you for that introduction. It is my distinct pleasure to welcome you to our session on the care we need, building a diverse health workforce. This is an incredibly important topic, and today we are joined by a group of esteemed panelists who I will now introduce. Our first panelist is Senator Clarence Lamb from the Maryland State Senate. Our next panelist is Dr. Noritsugu Naito, Chief of Cardiac Surgery at NYU Langone Hospital in Brooklyn. Paulo Pontemayor, Senior Director of Government Relations at the Catholic Health Association of the United States. Simit, Pandya, Director of Congressional and Grassroots Advocacy at the American Nurses Association. And lastly, Sofia, Aragon, Executive Director at the Washington Center for Nursing. Thank you all for being here today. As we begin, could each of you please introduce yourself, your organization, and spend 1 to 2 minutes describing the experiences you have had or work you have done to address health workforce issues? And we'll start with Senator Lamb.
Thank you, Rita. I'm happy to be here, and thank you to APAICS for sponsoring this. And so I'm Senator Clarence Lamb. I serve in the Maryland General Assembly, where I serve in the Senate and have done so for the last 8 years. Previously, I also served 1 term for 4 years in our House of Delegates as well. I'm currently the only physician in the Senate of Maryland, as well as the only Asian American. And so end up working on a lot of healthcare related issues, and also issues that are important to the Asian American Pacific Islander community as well. During that time, and outside the legislature, I'm also a physician on faculty at Johns Hopkins University, where I run the preventive medicine residency program as its program director. I continue to see patients every single week as the medical director for occupational health at the Johns Hopkins Applied Physics Laboratory as well. And so have worked for many, many years in blending together kind of this interest in health policy and public health, as well as being able to serve in our legislature, being able to help advance healthcare access, health insurance issues, and our public health system as well. And so when it comes to issues of workforce and being able to support a diverse healthcare workforce, it's an issue that's near and dear to me, both as a physician and as a policymaker. For the last couple of years, I've served on our state's commission to study the healthcare workforce shortage. It's a recognition that we as a state and as many other states around the country have probably identified as well, with an aging population, with more and more being placed on our healthcare workforce. Certainly a lot of challenges there to try to address. Happy to dive into that a little bit more as well. And for the last couple of years, I've also served on our state's public health commission, which has been really looking at how we can elevate our public health system as well as the public health workforce to be able to address the growing needs that have come out even after the pandemic, to help support and elevate our local health departments and state health departments. So look forward to the questions coming forward in this panel. Thank you so much.
My name is Noritsugu Naito. I'm a cardiac surgeon and the chief of cardiac surgery at NYU Langone Hospital, Brooklyn. I trained for cardiac surgery in Japan and the United States, both in Mass General Hospital and NYU Langone Hospital in New York. After serving as attending surgeon in New York City, I returned to Japan for 2 years as director of cardiovascular surgery there. And then I came back to the United States last April to lead this newly developed cardiac surgery program in Brooklyn. Our hospital is located in Sunset Park, where nearly 40% of the population is Asian and Pacific Islander. Our mission is to provide the same world-class care for complex cardiac diseases locally as in our Manhattan campus. For many patients, traveling to Manhattan can create significant burdens, both for the physical and financially. And some patients may miss opportunity for advanced care if it is not available close to their home. We focus on strong interpreter service, 24/7 available, multilingual patient education, including a video education software, and also building a multidisciplinary team that reflects the community we serve. These efforts help ensure patients understand their care and can fully engage in their recovery. Thank you.
It's very good to see everyone. I believe I've worked with many of you in the past, and as usual, I always love to sing the praises of APAICS, who really have these programs that really have transformed many professionals here in DC and across the country. In my day job, I work for the Catholic Health Association, which is the national leadership organization representing more than 2,200 Catholic health systems, hospitals, long-term care facilities, and other related organizations across the country. We form the largest network of not-for-profit healthcare, and we serve communities all across the country in every region, including rural, underserved, and vulnerable populations. Every day, 1 in 7 patients is cared for at a Catholic hospital. In my day job, I'm the Senior Director of Government Relations, where I lead federal advocacy on issues including Medicaid, coverage, maternal and infant health, and workforce policy. And so I help Congress, this administration, and other national coalitions understand the need for CHA's work and voice to advance really good health policy as it relates to the workforce. And a key part of CHA's work in this is to develop a more diverse, sustainable, and community responsive healthcare workforce. Many of our members and our systems were actually founded by Catholic sisters and nuns who really ventured all across the country, being part of communities, and saw that there was a community need for healthcare in their communities. And so policies that we advocate for include strengthening how these workforce pipelines can be moved forward, including expanding access to training and education, and providing support for rural and long-term care settings, which usually don't get a lot of the same attention as kind of the acute care space and in hospitals. We've been really working to promote culturally and linguistically appropriate care whenever possible. And so we want to make sure that that workforce is also representative of many of the communities that we serve. So I'm looking forward to today's discussion, and thanks for having me.
Hi, thanks for the opportunity to join everyone. My name is Simit, Pandya, and I'm Director of Congressional and Grassroots Advocacy at the American Nurses Association. I am also a first-generation Indian American. Just a little bit about ANA. ANA is the nation's nursing organization that represents 5 million plus registered nurses, as well as advanced practice registered nurses like your nurse practitioners, certified nurse registered nurse anesthetists, your clinical nurse specialists, and your certified nurse midwives. During my time at ANA, I've worked with colleagues and nursing community allies on and off Capitol Hill to champion congressional and regulatory policies that aim to expand the nursing workforce pipeline, address challenges that result in nurse burnout and attrition, remove red tape that restrict APRN practice, and modernize payment policies to be more equitable and recognize the value that nurses bring to their patients' bedsides every day. Thank you very much for having me.
Hello, everyone. It's an honor to be here with all of my esteemed colleagues. I'm Sofia Aragon. I'm the Executive Director of the Washington State Center for Nursing, and we're the State Nursing Workforce Center for Washington, and it's one of the top 5 states of highest concentration of API voters. So it's really important for us to be in this discussion. I've been in this position for 10 years, and what we do is first generate data so that we can create data-informed workforce policy for the state and also contribute to the national dialogue about a diverse nursing workforce. I'm also here as a member of the Philippine Nurses Association of America. And so there are some unique issues when it comes to the federal level, mainly immigration policy. And then at the state policy, we do have some unique challenges here that I'm looking forward to discussing with all of you. Thank you.
Thank you to all of you again for being here. Before we delve into a deeper discussion on this important topic, I'd like to go around the panel again and invite each of you to take 1 minute to share what you feel are the most important aspects of building a diverse health workforce that reflects the community served, with a focus on the Asian American, Native Hawaiian, and Pacific Islander communities. And this time, we'll start with you, Sofia.
I think for me, the most effective way to find solutions to workforce development is to actually ask the communities that we're trying to build. In my experience, when we interview or do research or focus studies on nursing students, for example, they tend to be much more diverse than our nursing faculty. So one study we did was ask both of them, what are strategies that we can do to promote nursing as a career among diverse students? And their top finding was actually promoting it to their families, because families were very important in influencing their career trajectory and also, to a great extent, helping finance their college education or technical education, wherever they wanted to choose. And when we asked nursing faculty the same question, it wasn't number one, it was actually more towards the bottom of their answer. So what that shows is that unless you ask the specific community, then you may not get the solutions that will actually be effective for them to be interested in the career that you are looking for. The other piece too is to, for nursing workforce centers, and I've done a lot of work on this in partnership with we have an Asian Pacific American Commission that is established by the state of Washington, is also work on disaggregation. So when we have a high percentage of Asian Americans in a state, you can have many communities within the Asian Pacific American umbrella. Here we have over 20, almost 30 groups. So it was really important when we collect data to make sure we have it disaggregated, because as you know, for communities that have been here for several generations, namely Japanese, Chinese, and Filipinos, that their situation and also access to education and healthcare could be greater and much more different than our immigrant communities that also come from other Asian backgrounds. So those are the things that we definitely need to keep in mind when we're doing workforce development here in the state of Washington.
Thanks, Sofia. Simit?
Sure thing. There are a number of things that come to mind. Number one, we need to enhance investments in nursing education and training programs that support all nurses, similar to those that comprise the Title VIII nursing workforce development programs. We need to expand support for the Substance Abuse and Mental Health Services Administration's Minority Fellowship Program, which aims to support and train psychiatric mental health nurses who can relate to the communities that they serve. We currently know that we have a shortage of those providers, and so we need to make sure that we're supporting them. And number three, I would say we need to make sure that all nurses, including those in the AANHPI community, have ample access to financial aid to help them through nursing school and pursue additional degrees, should they choose to do so. And finally, I would say we need to address the general challenges that often result in nurse dissatisfaction, burnout, and attrition from the nursing workforce, as well as those unique challenges to the AANHPI nursing community.
Thanks. Paulo?
Thanks for that question. And so when we think about hospital delivery or healthcare delivery, either in hospital settings or other care settings, the evidence is pretty clear that representation can actually improve care. Studies have found that when patients are treated by providers who share their racial or ethnic background, they may be more likely to accept recommended preventive care, and in some cases have better clinical outcomes, including lower readmission, especially at the hospital, or mortality rates. And that matters for Asian American, Native Hawaiian, and Pacific Islander communities too, because many times people believe that we're overrepresented in healthcare. I think that we all have heard those stereotypes that, as children, we were all trained to be doctors or nurses or, going into the healthcare workforce. But for many AA and NHPI communities, the policy challenge is that we often are just flattened by the model minority myth. AAPI communities are sometimes stereotyped as not facing serious health disparities, seen as being more affluent and not necessarily needing any other special attention or specialized treatment, and are already well represented in many of the settings that talk about affluence in American life. But the reality is that when you really dig deep into the subpopulations, many continue to face barriers in access, language services, mental health care, and actually leadership representation. That's why building a diverse pipeline of the workforce means developing and elevating A and NHPI leadership to push back on those myths. I can think of an example when I was in a room filled with healthcare associations and healthcare leaders, and I brought up the fact that we really should add a bullet talking about Asian American, Native Hawaiian, and Pacific Islander health disparities. And I got some pushback, being the only Asian American Pacific Islander in the room. And so I think that being able to advocate for our communities in really every single setting, including leadership settings, is an important piece. And I think that is part of the reason why we need to have forums like this and representation in policy settings.
Thanks. Dr. Naito?
So I believe one of the most important aspects is ensuring that the workforce understands the community it serves. In a place like Brooklyn here, where many of our patients are immigrants, language and cultural understanding play a major role in how patients experience healthcare. Diversity in the workforce helps bridge gaps in communication, health literacy, and decision making. So sometimes I experience, for example, many patients involve their family in healthcare decisions, and then understanding those dynamics is very important for building trust and proceeding with any high-risk surgery or complex patient care.
And finally, Senator Lam?
Yeah, thank you for that. I know it's always tough coming at the last end of the panel here, but a lot of the panels had pointed out some very good things, and I wanted to also just uplift the fact that it's important to have a diverse workforce of A and HPIs across the entire spectrum of the healthcare workforce. Because I think we are probably overrepresented at some of the higher positions, like physicians and advanced practice practitioners, but also recognizing that we need it across the full spectrum, everything from sonographers to dietitians to technicians to medical assistants to speech and language pathologists. We need to help elevate and model these types of roles for other A and HPIs to be inspired to serve in these capacities. That I think there's always a lot of drive for achieving the highest end of the hierarchy here, but I think our patients need to see people that look like them across the full spectrum of the care continuum. And so I think it's important to make sure that we also uplift these other roles that are just as essential in a interdisciplinary environment where our patients will interact with many different levels and types of providers for them to see this reflected in them as well. And so just wanted to kind of uplift that in addition to everything else the panelists have said.
Yeah, these are all important issues that do need to be addressed in order to ensure a diverse health workforce. Thank you for all those comments. We'll now transition into a moderated Q&A discussion to further discuss the need to build a diverse health workforce to meet the needs of our communities. And I'll start with you, Senator Lam. In your role as a Maryland State Senator and also a physician, can you describe in greater detail the work you have done at the Maryland state level to address health workforce shortages, challenges you've encountered in your work, and what would be necessary to replicate your successful work in other states?
Thank you, Rita. And this is certainly an issue that we've seen in the state of Maryland here, where I represent, but also other states around the country. As I mentioned at the top, we have certainly an increasing population that has vastly growing healthcare needs. And as we understand in our science advances, the needs are only going to continue to grow. And we're facing a lot of challenges, both in the traditional healthcare space with a lot of providers exhausted or retiring after the COVID-19 pandemic. And it's a pipeline that's not easy to be able to just turn on and off, right? So for all these different levels of healthcare workers, it takes years to be able to train these individuals to take on these roles. And we've certainly seen a lot of folks leave these positions. The one area that I'll focus on that I think is also would resonate with this audience is that we do have a lot of foreign trained healthcare workers that are available to be able to take on these types of roles. But it's very, very difficult for them to be able to navigate a lot of the complexities of licensing and residency and board certification and being able to qualify for reimbursement. And so an example of what we've done here in the state of Maryland is for nurses. We've tried to make it easier for nurses that may have practiced in other states as well as may have been trained in other countries to be able to practice here in the state of Maryland. Oftentimes, nurses will have to go through, particularly foreign trained nurses may have to undergo certain English language requirements, pass through a test in order to be able to demonstrate that they're English language proficient to be able to serve as a nurse here in the state of Maryland. One quick example of what we did here was accept any nurses that may have already passed similar English language proficiency in another state. So if they did that in, another state, have already demonstrated that they're proficient, there's no need for them to have to demonstrate that here in the state of Maryland for them to be able to obtain a license. Oftentimes that there's also reciprocity agreements that will help them through that process a little bit faster. But that's one layer of red tape that we could eliminate here at the state level. Another quick example is that we see a lot of foreign trained physicians that may have done residency in medical school in another country, and it is very difficult for them to be able to come here in the state of Maryland to seek a license and have a pathway to licensure without having to go through another residency here in the United States. And it is very difficult, and I know this as a residency program director, very difficult for a foreign trained physician to be able to be accepted and complete another US-based residency. So you have a lot of foreign trained physicians that may have been practicing as attending physicians and have years under their belt come here to the United States, and they're oftentimes just maybe doing research or maybe functioning well under their ability to practice because it's difficult for them to get a license or difficult to go through a second residency all over again to demonstrate things that they've already completed in another country. Several other states, I think there are about a dozen other states, are looking at how we can streamline this process as well for these foreign trained physicians to be able to have a pathway for them to practice without having to go through a full residency. And so I think that's worthwhile as policymakers and those working in the policy field to look at this as another possibility to help expand our workforce.
Such important issues that you've been working on, and thank you for sharing that. Next, I'll go to you, Dr. Naito. From your perspective as a physician leader at a large academic hospital, can you describe the composition of an ideal interprofessional and diverse health workforce to comprehensively address the needs of patients and communities served that also provides culturally and linguistically appropriate care? Also, at the clinical level, what does it actually mean to have a health workforce shortage or a health workforce that does not reflect the diversity of the community served?
Thank you for the question. I think multidisciplinary workforce is very essential to sustain high quality care, especially in high skills, highly specialized field like cardiac surgery. Patient care requires a coordinated team that including nurses, nurse practitioners, physician assistants, and physical therapists, case managers, and also community health workers. Each of these roles contributes to different aspects of the patient care. For example, after cardiac surgery, recovery depends not only on the surgical procedure itself, but also on rehabilitation, medication management, discharge planning, and also community support after discharge. When this team includes individuals who share language skills or cultural background with the patient we serve, communication becomes more effective. And at the clinical level, workforce shortage often means providers have less time for communication and patient education. In diverse communities, And in the field of complex patient care, this challenge is even greater because discussions may require interpreter and additional time to address cultural perspectives on illness and treatment. When the workforce does not reflect the diversity of the community, patients may feel less understood, and these gaps in communication can ultimately affect access and engagement and outcomes. Thank you.
From your perspective, representing hospitals, long-term care facilities, and other health facilities nationwide, can you share some challenges with health workforce staffing shortages, particularly in rural areas and long-term care facilities? Also, how will upcoming Medicaid cuts and the expiration of the ACA enhanced premium tax credits impact the health workforce shortage?
Thanks for that question. I feel like I've done the roadshow talking about the impacts of these upcoming changes. Rita, as you mentioned, these are things coming down the pipeline because of HR 1. And first, we have to recognize the financial reality. For many hospitals, health systems, long-term care facilities, and nursing homes, staffing actually accounts for more than half of total expenses. And in some settings, especially in long-term care or in rural facilities, it could be closer to 60%. So in these proposed Medicaid cuts, total close to $4 billion, which is a number that we've developed internally, in just 1 year across Catholic hospitals and other Catholic healthcare settings. This is actually a huge challenge for how we can think about workforce growth, diversity, or retention without also protecting how financing is such a huge part of the staffing question. The same is true for the expired enhanced premium tax credits, which actually expired last December. And it is depending on how this year goes, millions could lose coverage. And this means hospitals will see more uncompensated care, more people accessing healthcare through emergency rooms, which all lead to lower revenue, making it harder to invest and sustain and grow the workforce. Medicaid, Medicare, and coverage policy are really not separate from workforce policy. They are what makes it possible to actually operate in many facilities and for not-for-profit care with some of these very small margins or negative margins. The challenges for developing the workforce there is also a community-wide issue because communities also depend on many of our facilities as anchor institutions, especially in rural areas. Secondly, we are also looking at how the workforce pipeline needs to be done in a more equitable and intentional way. We've seen what Congress and this administration can do to really strengthen workforce. In the last appropriations bill, they actually renewed many workforce training programs. But we've also seen that the challenges, as Senator Lam has mentioned, around immigration and getting immigrant healthcare providers to come to this country to fill some of these shortage gaps, especially in rural and underserved areas, is a big part of healthcare workforce policy. Internationally educated clinicians, nurses, aides, and other healthcare workers are essential to filling some of these persistent shortages that we've seen. The challenges with Medicaid cuts in HR 1, especially in rural settings, will force many providers to actually close their doors. So that also means that those opportunities to employ healthcare workers are going to be gone. And once you close an essential critical access hospital or facility, it's really hard to open them again. And so we need to think about a proactive way that we can target federal investment, including thinking about visa and immigration pathways to think about how we can continue to maintain our workforce, especially as we look to the future with an aging population and a shrinking population as well, that we need to be very creative and really mindful for how we can uplift the dignity, not only for patients who visit many of our facilities, but also many of the workers who come to work at our facilities. And we need to do that right now and not in the future. Thank you.
Thanks. Simit, I'll go to you next. At the national level, can you briefly describe some of the biggest challenges contributing to the nursing workforce shortage? I realize you touched on some of this earlier, but if you could just touch on a couple more things, that would be great.
So I'm going to put the challenges facing the nursing workforce into three categories: nursing workforce pipeline challenges, work environment challenges facing nurses in the bedside, and finally, regulatory burdens that APRNs face when trying to treat patients. So first off, I want to point out that we are facing inadequate investments in nursing education. Despite being the largest and most trusted profession in America, we're not adequately investing in nursing education to support our aspiring nurses and those seeking higher education. This year, for example, Congress approved a fiscal year 2026 appropriations package that gave the Title VIII programs static funding in the amount of $305.472 million. This is discretionary funding that the nursing community has to seek every year. In contrast, Congress provided $17.8 billion in mandatory spending for graduate medical education. That kind of gives you a contrast in terms of how little our country is investing in nursing education. I want to also point out that part of the problem with our with being able to attract more nurses is the fact that we don't have enough nurse faculty and nurse preceptors. According to the American Association of Colleges of Nursing, nursing schools in the U.S. turned away more than 100,000 qualified applicants in 2024 due to insufficient number of nurse faculty at those nursing schools. Non-competitive salary was a leading reason for the shortage of nurse faculty. There's also a national shortage of nurse preceptors to train early career nurses and seasoned nurses who may be new to certain nursing specialties. This reality has negative implications for the nursing workforce, healthcare delivery, and patient outcomes. The third thing I want to point out is certain changes that happened through the One Big Beautiful Bill. These are reforms to federal graduate student financial aid programs. So a little bit of background. HR 1 eliminated Grad Plus loans, capped Parent Plus loans, and outlined new income-driven repayment plans. It also created a two-tier cap for graduate student loans. Graduate programs are capped at $20,500 per year with a $100,000 lifetime cap. Professional programs would be capped at $50,000 per year with a $200,000 lifetime cap. There are no changes to the regulatory definition of professional degree. However, the proposed rule that came out last month implements reforms that exclude post-bachelor's degree nursing programs from the professional degree category. So that means nursing students would be subject to the lower caps under HR 1. Other thing I want to point out is working conditions driving burnout and driving burnout. Things like the overuse of mandatory overtime for nurses, especially in areas experiencing severe staffing shortages. Workplace violence is another area of concern. 1 in 4 nurses report being a victim of workplace violence, and many of those incidents go unreported. We have inadequate support for nurses and other providers experiencing mental health or substance use disorders. Often this is associated with stigma, particularly in our communities. Higher exposure to underreporting of discrimination, lack of support for internationally educated nurses, underrepresentation and leadership. Those are just some examples. And then finally, we have Medicare regulations really hinder APRN's ability to practice at the top of their education and clinical training, even in states where they're allowed to do so. And that results in less access to nurse practitioners and other APRNs who would otherwise be able to provide primary care services to patients. Thank you.
Thanks. And Sofia, through your work in Washington State, can you discuss some of the unique challenges that states face when working to address nursing workforce shortages and how these may affect the Asian American, Native Hawaiian, and Pacific Islander community?
Well, I think Mr. Pandya was actually right on in terms of our shortage of nurse faculty. So this, in terms of nursing shortages, I want to point out that they can differ from state to state. There's few differences that in shortages with registered nurses and licensed practical nurses, but in the advanced practice nurses, that's where the data may differ. So when we looked at demand projections for nursing here in the state of Washington, our number one role that's needed in 2032 is the nurse practitioner, and second to that is the nurse educator. And another unique thing that you'll need to know about states is that nurse practitioners, their scopes of practice can really vary. And Washington has enjoyed a very broad scope of practice. For example, one of the roles that is emphasized here, the psychiatric nurse practitioner, our legislature actually chose them to have just as broad a scope as psychiatrists. So that really improves access to care here in terms of psychiatric mental health. But I also want to say, because, many of us here, and there's a lot more information I think that's said in the clinical environment or inpatient environment, is that we can do a lot about prevention when it comes to mental health. And so in terms of schools, there are school nurses that I think have a good role in expanding, identifying risk factors for children for mental health, as well as public health nurses that could also provide services to address that need. So I think looking at prevention and community health, recognizing that is as important as inpatient, I think will do us really well when we're talking about building the nursing workforce. The other unique challenges, and because this is a forum for Asian Americans and Native Hawaiians, is really looking at demographics of the state. So in the state of Washington, the top population that are now graduating out of our high schools are the Native Hawaiian Pacific Islanders. However, if you look at nursing data, they only represent 1% of our entire workforce, which to me is that we have to do a lot more work when it comes to inclusion. Nursing shortages don't ever seem to go away. They tend to occur, but for different reasons. And unless that our role, our profession is broadly appealing, we're not going to be able to address that shortage. But it's really important to see which group is up and coming that is going to be entering our schools and making sure we are prepared to include them. And another thought about that too is what we've been doing in Washington is really aligning with the STEM community and actually trying to encourage kids at a younger age. So we actually go into middle schools. We have schools of nursing with their students. Part of their clinical experience is to reach out to middle school students, and our data has shown we can increase interest in the role by double with before and after evaluation. So you really need to, I think, try innovative ways and also really keep pulse on what are the student communities looking like, and how are you connecting your role with the students so that they're interested in joining the profession as they prepare for their academic track, high school and beyond.
Thanks so much, Sofia. And thanks to all of you for such a robust conversation. What an important and insightful discussion on the critical topic of building a diverse health workforce to comprehensively serve the needs of our communities to improve health outcomes. I'd like to thank each of our panelists again for being here today and for sharing your insights and expertise with all of us. And I'd like to thank our audience members for joining. Thank you.
What a great day of important conversations. I hope you've learned as much about the healthcare landscape as I have from our esteemed panelists and featured speakers. Before we close, I'd like to recognize our summit partners, Amgen, Biogen, Blue Cross Blue Shield Association, Bristol Myers Squibb, Compassion and Choices, DaVita, Johnson & Johnson, NYU Langone, Pharma, and Planned Parenthood. Your generous support enables APAICS to fulfill its mission of promoting Asian American and Native Hawaiian Pacific Islander participation and representation at all levels of the political process, from community service to elected office. If you'd like to learn more about the work that APAICS does, please visit apaics.org. I look forward to continuing these important conversations in the future.